Um, that's not good.
Okay.
I'm sorry. I'm the one who's more nervous. Um, I'll just do the script. This is an interview with Dr. Daniel W. Brake of Charleston, South Carolina, who served as president of the South Carolina Medical Association from 1989 to 1990. This interview is being conducted by Bruce Robinson in Charleston, South Carolina on June 12, 1992. Dr. Brake, where were you born?
I was born in Lake City, South Carolina, a small rural community of about 8,000 population.
Who were your parents? Were they from Lake City?
My mother grew up in Lake City. Her grandfather was granted some farmland from the King of England and had large family in that community. My father moved to Lake City from North Carolina to come work for his sister's husband, who was a general practitioner in Lake City and owned a drugstore. And he came to work for him and met my mother, and they married and stayed in Lake City where I grew up.
So obviously medicine runs in the family.
Yes.
Whoa, excuse me. I'm sorry.
Yes, sir.
Let me stop this for a second. Obviously. Here we go. This is an interview with Dr. Daniel W. Burke of Charleston, South Carolina. My name is Bruce Robinson. I'll be conducting the interview. Dr. Burke served as the president of the South Carolina Medical Association.
This is Brake, B-R-A-K.
I'm sorry.
No problem.
This is an interview with Dr. Daniel W. Brake of Charleston, South Carolina, who served as president of the South Carolina Medical Association from 1989 to 1990. Dr. Brake, where were you born and who were your parents?
I was born in Lake City, South Carolina, a small rural community of about 8,000 population. My mother was Gladys Nettles Brake. She grew up in Lake City, South Carolina, had a large family in Lake City. My great-grandfather had a large farm that was granted by the King of England, and they had families of 7 and 8 children, and all of them married, and all of their children had children, and the community there I was related to just about everybody in the small town. My father was from North Carolina, and he moved to Lake City to work in a drugstore that his sister's husband, who was a general practitioner, owned at that time. He met my mother, and they married and had me and my sister, and we grew up in that small rural community.
So was this much of an influence on you as a decision to go to become a physician?
Yes. My uncle, who was Dr. Dexter Evans, was the ideal old general practitioner, and he had a son that went to med school and came back to practice with him in Lake City. My uncle, his whole life was dedicated to the people in that community. We never had dinner with him that he didn't get a phone call or have to go out and leave and take care of a patient. I never heard him complain. When he died in that community, I've never seen a funeral like that people were out in the streets and could not get into church, and everybody just paid their respects to a man that had dedicated his life to that community. Those kind of physicians and that kind of dedication back in the 40s and 50s are something that's difficult for me, and I think younger physicians to understand. They basically gave their entire life to their community. They had very little family life, and they were all on call. They were individual practitioners, and it was just a tough life, and I admired him greatly, and that's why I went into family practice.
In some respects, I can't think of a stronger influence than anything else to enter family practice. Did you know this then when you became an undergraduate, that you were obviously on the road to becoming a physician?
Yes, actually, I was one of the fortunate ones, I guess, because by the time I was about 8 or 9 years old, my views of my uncle and feelings of wanting to be a general practitioner were very strong at that time, and those were my goals, and I headed in that direction, and I never turned in any other direction except medicine. At family practice at the time, it was general practice when my uncle was growing up, and the large percentage of the physicians at that time were general practitioners. And then we've evolved into a specialty area where everybody was specializing in one field or another, and the general practitioners seemed to be dying out. And so as I went through med school and I went through my residency program, each service that I was on, whether I was on internal medicine or pediatrics, I loved the service, and the people in that, the professors in those areas would tell me, you don't want to be a general practitioner, you want to go into internal medicine or pediatrics or whatever because general practice is dying. Well, fortunately, the general practitioners got together and formed their own specialty called family practice and set up a 3-year residency program where we could get better education and continued education and recertification of our boards and provide quality care for the entire family. And so at times I got a lot of pressure not to go into family practice, but I've always wanted to do that, and I'm very happy that I did.
Do you see a lot of students today entering into family practice?
The family practice has had its ups and downs, and right now, because of a lot of things that are happening to the family physician as far as the government is concerned, and Medicare reimbursement has been extremely poor for the primary care physician in family practice, and that a smaller number of med students are going into family practice. But the nation realizes how important it is to have somebody at the front lines of seeing the patient. The subspecialist really cannot survive without a primary care physician seeing the patient and making a diagnosis and referring them to the proper subspecialty area. So there's another movement going on now in med school as a core curriculum in family practice now to expose the medical students to family practice, and I think we will again see an increase in family physicians as we did in the late 60s and early 70s.
So you believe these programs are, for the most part, effective?
Yes.
That there will be more of an enticement into family practice?
Exactly.
For today's modern medical student. Do you believe then some of the shortcomings, perhaps a lot of medical students were not at all made aware of the rewards of family practice, the rewards of long-term follow-up, of seeing a patient's birth through death, of dealing with family as a unit? Do you believe that those would be some of the shortcomings to why people went into a number of certain specialties? Do you believe it was just perhaps in some respects, the lower monetary remuneration? What do you think were some of the shortcomings? What caused this lack of
Well, I think one that as a medical student and even in my internship, as I would work on a service, a pediatric service, I thought highly of a pediatrician, loved the pediatric service, and thought about being a pediatrician. Although I knew in the back of my mind I wanted to be a family physician, but if I wasn't going to be a family physician, maybe I'd like to be a pediatrician. I got on the internal medicine service, and the internist there and I became great friends, and so he said, listen, you ought to go into internal medicine, and I thought internal medicine was great, but I knew still I wanted to be a family physician, but you didn't have the exposure of what is family practice like. You weren't in a family practice department. You didn't have the exposure of what is family practice really like. And without that exposure, students that don't really know what they want to do don't get a choice of family practice. They get a choice of surgery and internal medicine and pediatrics.
Do you believe the South Carolina Medical Association, and with its powers and abilities and people and membership, could play any influence in increasing interest and stimulating interest in students becoming family practitioners?
Yes, actually, I think South Carolina Medical Association, as well as now both our schools of medicine, the MUSC and the South Carolina School of Medicine in Columbia, have core curriculum that actually have medical students. We have medical students that come out and work in my office. In fact, we've got one now that is working with us to see what family practice is really like. The thing that you can't get in med school in any field is you can't really, you're not there long enough to build a relationship with the patient. And the patient is what, to me, it makes family practice so rewarding, because not only are you seeing a lot of variety and a lot of interesting disease from a scientific standpoint, you also are building a relationship with a human that you care about. And you can relate that to the patient, and the patient appreciates having a physician that cares about them, and they know when we care about them. They know if we don't care, and they know if we do care. So for us to be able to not only take care of them from a medical standpoint, but to be somebody that cares about them, I think is rewarding for the patient and very rewarding for me as a physician.
Earlier you mentioned first residency in the medical school. I'm going to backtrack a little. Where did you do your undergraduate work?
I went to Wofford College in Spartanburg, South Carolina. A very small college that is a liberal arts school. That we had, interesting, we had 13 students out of a class of about 90 that went to MUSC School of Medicine. And a lot of doctors that come out of that college.
That's a big portion. Did you follow suit?
Yes.
You were one of the 13, lucky number 13?
Yeah, sure was.
Did you do your residency here also?
No, but I'll tell you something interesting about when I graduated from Wofford, I came to medical college. It was called the Medical College of South Carolina in Charleston, which is now the Medical University of South Carolina. I came into that class, and we had a small class. We had a dean at that time called Chavis Smythe, and Dr. Smythe, at that time, South Carolina was not rated high in the country for medical schools, and he decided that when we stepped in the first day, he told us that he was going to graduate the smartest class from South Carolina or the smallest, and he was going to put South Carolina on the map with our class. And he drilled us for national boards. He worked us extremely hard, and we graduated the smallest class that had ever graduated, because he flunked 12 out the first year of a class of around 80 to 90 students. But he really worked us hard, and he actually helped to improve the quality of the teaching and the students at MUSC.
Your nemesis or your mentor, depending on which way you look at it.
Right. But then I did my internship in North Carolina at Charlotte Memorial, and did my residency in family practice at Charlotte Memorial Hospital.
Tell me some of the highs and lows of your residency.
The interesting thing of residency was I made 15 cents an hour. We had a flat monthly salary that we got, and we sat down and calculated the number of hours we worked and figured that we were making 15 cents an hour, and worked extremely long hours. I married between my junior and senior year. I married Sue Roach from Pinopolis in Moncks Corner, South Carolina, and we were there working extremely hard, and that was one of the happiest times of our lives. We stayed in an apartment that was right beside Charlotte Memorial Hospital that the residents stayed in, and we all were in the same boat. We had no money, and we were working extremely hard. We were learning a lot. It was an exciting time, and it's just a fond memory for me and my wife. And also my daughter was born there, Shannon, which was an exciting time for us too.
You have just the one daughter?
I have two children. Shannon is just graduated from Emory in Atlanta, and is now doing research with Yerkes primate research, and has just been awarded a fellowship for cultural anthropology and at Emory, and we're real proud of her. And my son Daniel was born in a rural area I practiced in Conway, South Carolina, and he is a junior at Wofford College, and right now is at the University of Salzburg in Austria, where Wofford has an exchange program, and he's spending a semester over there, which is a wonderful experience.
Do you by any chance see him following in your footsteps?
Um, Daniel is just a wonderful young man, and I really, at this stage in his life, he's one of those undecided on where he wants to go. He knows that physicians have to work hard and have long hours and don't get to spend a lot of time with their family, and I'm not really sure where he'll head.
Tell me about when you left Charlotte. Where did you go?
Um, at the time I left Charlotte, when we were in med school, everybody had to serve 2 years in the service. And what happened was that you either finished med school and you got in your internship and residency and you got drafted, or you finished that and you went out and started practice and you got drafted. So the military allowed you to sign up for something called the Baird Plan. And the Baird Plan would allow you to finish your residency, and then as soon as you finished training, you could go in and serve your 2 years in the military, and then you were through with the military and you could go out and open your practice and not worry about being drafted. So I signed up for the Baird Plan, and as soon as I finished my family practice residency in Charlotte Memorial, then I went to Wright-Patterson in Dayton, Ohio at a base there, and worked in the family practice clinic there for a year. And while I was there, I was watched the hospital, and I had a general one day ask me how things were going, and I told him a number of things that he could do to improve the quality of care in that hospital. And he was so impressed that he gave me my own hospital in Greenland, and he sent me to Greenland, which is a remote assignment for my second year in the service, and I had to send my wife and my daughter Shannon to Moncks Corner, South Carolina to stay with their parents while I spent a year in Greenland in this hospital that I could have really good quality care. And because I was the only physician there, and we had about 14 corpsmen and administrators that worked that hospital.
At that point, were you looking, at the very end of that, were you looking very much forward to coming back to the United States?
Yes, I was very excited about getting out of the military and getting into family practice. The sad thing for me in that year was that that was the year that I was going to spend deciding where I wanted to practice. And I knew that I wanted to be in a good hospital setting, and I knew I wanted certain things in the hospital to provide the quality of care that I had been trained to provide in my residency program. But yet I couldn't go from Greenland to look at different practices. So Dr. Dick Rush, who was from Lake City, was in practice in Conway, South Carolina. And his mother contacted my mother, and they contacted me and said, when you get out of the service, why don't you go practice with Dick in Conway until you can decide what you want to do and where you want to go. So at least I would have a job when I left the military until I could decide what I wanted to do. So I went straight to Conway and started practicing there, and started looking around at other areas, trying to decide where we wanted to go, and actually ended up staying in Conway for 10 years before we moved to Charleston. The Conway experience, as far as rural medicine was concerned, was really kind of like the medicine that my uncle practiced, and was fun.
What was the population?
Population was about 8,000, and it was in a county called Horry County, and it was a fairly poor county. There was about 30–40% of the population were basically on Medicaid, which was the insurance for the indigent population. And patients, there was a lot of farming around, and when I first opened my practice, a patient, after I saw him and he got ready to leave, he said, "Doc, I don't have any money." And I said, "Well, you just do what you can do." And he said, "Well, you like corn?" And I said, "Yeah, I like corn." He said, "Where do you live?" And I told him where I lived. And he said, "Well, I'll go get you some corn and take over to your house." And I said, "Well, that'll be fine." And so I told him I had a little patio in the back of the house, and I got a call from my wife that afternoon, and she said, "Dan, what did you do?" I said, "What do you mean what I do?" She said, "Some guy backed a pickup truck of corn and dumped it on our patio. I've got a whole pickup truck load of corn out here. So we had to go buy a freezer to put up all this corn and put it in my freezer. But they paid us with butter beans and corn and squash and potatoes and whatever they could. And that was one of the things that I miss in medicine today because of all the insurance and the paperwork and the expense. When I was practicing in Conway, and my uncle, basically, and watching him, he rarely sent out bills. I mean, people came in and the majority paid him. And the ones that couldn't pay him gave him butter beans or corn or nothing. And he didn't have all this insurance claims to fill out. And he got along fine. He made a decent living. He was able to pay his staff properly, and didn't have to harass anybody. And that's kind of the way it was in Conway when I first started practicing. And it's sad to see us move to the expenses that we have to deal with in medicine right now, the expenses that patients have to deal with, and have to try to meet the tremendous overhead that we have to practice right now. And that really discourages a lot of young physicians going out and opening their own office, because it is so expensive to open an office today. But those were fun times in the rural area there.
Dr. Brake, what brought you to Charleston?
Well, I think probably my family and my children grew to the point that we loved Charleston. I spent my medical school years here. My wife was from the Charleston area around Moncks Corner. She has 5 brothers and sisters, and they're all married, and they all have children, and they all live in this area. And so we just felt like it was time for us to. My daughter was into eventing and horseback riding, and she was not able to get some of the training that she needed in that area, which was available here. And my wife came and looked. We talked about trying to move back to Charleston, and my wife came and looked and found a house site out at Middleton Place, Middleton Gardens, which is the first landscape garden in America, and Arthur Middleton owned this plantation, and he signed the Declaration of Independence. So it's a beautiful old plantation of about 6,000 acres. And at that time, Charles Duell, that owns Middleton Place, opened up some house sites, and she found one of these and came and looked at it, and got me to come down and look, and we walked over the plantation and looked at this beautiful old plantation. And when I was growing up, my mother took me to Georgetown, where there's an old plantation there that we rode down, and I saw these beautiful oak trees. And I was 10 years old then, and I told my mother at that time that I'm going to own a plantation someday. Well, obviously I could not possibly afford a plantation, but here I could buy about 1.5 acres on this old plantation. They have 6,000 acres access to walk in the gardens at any time I wanted to, and so we fell in love with that area. They had stables that my daughter could ride, and all this property for her to ride on. So we decided to try the city living for a while, and I was 40 at the time, and moved to the Charleston area and opened an office, and people told me I was middle-aged crazy, and I probably was. So I had not one patient when I opened this office, and said I hope somebody will come to see me, which they did, and at the present time now we have 3 doctors in the practice, and we're looking for a 4th, and so it really has worked out well, and we've enjoyed being in the Charleston area.
It's probably best for the SCMA too, because being in the Charleston area, is it safe to say that that probably stimulated some of your interest with the SCMA?
Yeah. Well, what happened to me with the SCMA was that at the time I was in Conway, I admitted a young boy with Hodgkin's disease who was not doing well, and I was concerned about him. And I kept him in the hospital 3 days, and I sent the insurance company a bill for the history and physical and the 2 days in the hospital and the discharge summary for a total of $35. and the insurance company sent me a check for $35. And about 6 months later, I got a letter from the insurance company saying that this was a diagnostic admission and they had denied the admission, and that I needed to send them the $35 back, or they were going to take it out of the next check that they sent me for whoever I had in the hospital. And I was just furious, and I went to a doctor named Desi Gillum, and Desi was at that time president of the South Carolina Medical Association. And I said, Desi, this is just not right, and you guys in the Medical Association need to do something about it. And he said, well, son, if you want to do something about it, then why don't you get active in the South Carolina Medical Association and do something about it yourself? And so Desi, at that time, they formed a South Carolina Medical Association Insurance Peer Review Committee. And so he put me on this committee, which actually was looking at physicians that were overutilizing services for hospitalizations and office work, but it also gave us a look at the insurance companies and who they were using for doing their review work to deny admissions on medical necessity. So they were doing this retroactively. It was very easy to sit down and look at a chart and say this patient didn't need to be in the hospital because they didn't turn out to have cancer or whatever you suspected they had. But at the time that you're looking at the patient, trying to decide what's best for them, then if you feel they need to be in the hospital and you admitted them, and it turned out with something bad, it was okay. If they didn't, then you could get these retroactive denials. So through that committee, and one of the things that I'm proud that I was able to accomplish at that time was that I worked very hard to fight retroactive denials. I told them that they needed to do concurrent review, they needed to do review at the time that the patient was admitted to the hospital, and decide at that time, are we going to pay for it or we're not going to pay for it. And so we were able to get rid of retroactive denial process, and we did it basically through that committee and in working through the South Carolina Medical Association. I became chairman of that committee, and then was asked by some of the board members to serve as a first vice president, which was really a position that allowed the board to go out and get people that they thought might be effective for the organization and get them in that position, get them on the board and take a look at them. And so they kind of brought me on the board that way.
So that was a stepping stone to the presidency.
Yes.
Tell me about your term as president.
Well, it was a wonderful year. It was fun. And one of the things about South Carolina that I just love, and one of the reasons I wanted my son to go to Wofford, is that it's a very small state. If you go to a small school like Wofford and you go to the Medical University, MUSC School of Medicine, most of the people you run into are South Carolinians. And you become good friends with people just about everywhere. And so there's not a city in this state that I can think of that I can go to that I don't know somebody that was at school with me somewhere at Wofford or med school or know somebody that I know. And so to go to all the county medical societies and to meet these people again and see them that I haven't seen for a long time was really fun. In fact, it was interesting when I went to Rock Hill. The president of the County Medical Society met me, and his name was George White. And so we got to talking, and I asked George where he was from. He said he's from Rock Hill, and I asked him if he knew a guy named Spratt White. And Spratt White was a fraternity brother of mine at Wofford, and we sang a little group together, and he and I were just good friends. And we went to, I went home with Spratt one weekend, and he had a large family. And they had this little boy that was about 2 years old there, and he just gave us a fit. He was just a real brat. And so when I got talking to this guy that was about 6'4", he said, yeah, Spratt White is my brother. And I said, you are George White? He said, yeah, this was a kid I had not seen since he was 2 years old that now is president of the County Medical Society. But everywhere I went, I ran into somebody that we knew somebody together, and that was fun. One of the tragedies of my year as presidency was that was the year that Hugo came to Charleston, and it really was devastating for us here in Charleston, and it really was hard for me at home. We didn't get electricity at our house for 3 years. I mean, for 3 weeks, and we lost 53 trees in the yard, and we had 14 on the house, and so we had a lot of problems there, and it made it difficult for me to be doing some of the things that I needed to do for the Medical Association. I had to go to Hickory Knob to talk to a Senate meeting that they had there, and I would have to leave my home at 5 o'clock. Well, I finally bought a generator that would get us water and into the house and some electricity, but not enough to get hot water. So I couldn't take a hot shower, and I wasn't going to take a cold shower at 5 o'clock in the morning. So I got up and headed to Hickory Knob with no shower, no shaving, and I decided I'd do something on the way. Well, when I came to Aiken, I said, well, why don't we try a motel? So I pulled in the motel and went in and said, how much you charge me for a shower and a shave? And he said $20, so I gave him $20, and I went in and got my shower and shave, and then left and went on to Hickory Knob. But Hugo was a rough time for us. A lot of doctors went out to some of the rural communities and provided health care, and South Carolina Medical Association got involved in funding some things to help some of the devastated areas.
Tell me about some of the administrative policies during your tenure as president of the SCMA.
Well, some of the things that well, let me just kind of tell you some of the things that I think were appropriate, outstanding, and tended to head us into certain directions. There was a personal care program that we set up through South Carolina Medical Association, and this really came through with Tommy Rowland's-Stern. But what we were saying was that Medicare was the insurance plan that the government set up for the over 65 population. At the time that Medicare came out, the American Medical Association said to the government, you know, you only need to cover the people that can't afford to pay for themselves. That's what the government should be doing, in my opinion. And you shouldn't try to cover everybody, but the government knows we'll cover everybody, so that everybody over 65 gets Medicare. And Medicare was initially paid current fees, and it was not able to keep up with it, as government programs usually are not able to. So they started having to play games to try to keep the cost down. And so they put freezes on what they allowed, their allowed charges. And as inflation continued to rise, and in the 70s we had sometimes as much as 20% inflation rate, the fees for Medicare reimbursement were staying way down here. And so the difference between what Medicare would allow and what physicians were charging was getting tremendous, and the Medicare population was not very happy with that. So they went to the government and said, you know, we want you to force the doctors to accept these low fees you're paying. So if you had a $20 service, Medicare may not allow but 10, and they pay 80% of that, which would be 8, and the patient would be stuck with a $12 bill for the rest of the bill if they paid a physician. If they could get the physician to accept assignment, then he only paid $10. That would be all the patient would be charged. And so the insurance company and Medicare paid, and the patient would be left with 2. But the allowed charge didn't cover your expenses, so you couldn't do that and keep your office open. So most physicians in the primary care field didn't accept assignment, and they pushed very hard to get us to accept assignment. The personal care plan, what the physicians said were, from South Carolina, that we care about the older people that on fixed incomes that can't make ends meet. And we will accept assignment on anybody under 150% poverty level. and we went through the Commission on Aging, and I met with them a number of times to show them this plan, and we then said anybody above that level, then the physician would deal with like he does any private patient. Now, I got private patients that don't pay me anything, and I've got some that pay me half of what I charge and some that pay all. But you would deal with them as an individual patient, not as a Medicare patient. And the personal care patient could bring their card in, the physician would accept assignment. So that was a good program that is still in effect. And we moved from that program into looking at during Tommy Rowland's era, to looking at the healthcare crisis situation, which has evolved now into 1992, and everybody wants something done about the healthcare system. It really is it's too expensive. Patients cannot afford the premiums for insurance. So if I can move into my year and tell you what I think is the most important thing that I did as president that I'm proud of, is that I had tremendous concerns about what was going to happen with health care for me in my older years, and what kind of health care my children would be able to receive. And so I formed a committee that I called Healthcare 2000. I asked people from the government, people from private insurance companies, hospital administrators, nurses. We asked people from the AARP, Medicare recipients. We asked everybody that provided or received health care or had anything to do with health care to sit down at a table. And the first day I asked them, what kind of health care do you think we should have in this country? I asked them to take off their special interest hats and be Americans, and not sit there and try to set a system that would benefit them in whatever field they were in, but a system that would benefit all Americans. And I was extremely proud of that committee. They did just that. We came up with some recommendations. I told them, let's look at all the socialized system. If America should be socialized, then let's push and get the South Carolina Medical Association to move towards socialized medicine. If we felt like that was not the answer, then let's look at our system and see what's wrong with it and try to correct it. Well, we decided after looking at the socialized system that they had big problems, and that was not what we wanted. We decided that we had the best health care in the world, but it just cost too much, and it had some flaws in it that needed fixing. So briefly to summarize what they recommended, and maybe to, if somebody's looking at this in the year 2090 or whenever, it'd be interesting to see what kind of health care system that you have now compared to what we are recommending in 1992. But to summarize briefly, what happened was when Medicare and Medicaid were passed in 1965, the government pretty much paid for things as they received it. When the services became so large that they couldn't afford to pay for it, then they started cutting reimbursements. And they cut reimbursements to the point that people actually lose money taking care of government patients. So the hospital ended up with about 55% of their admissions on Medicare and Medicaid, and they were losing money on all of them. So all they could do is cost shift to the paying patient. And as they shifted their cost to the paying patient, then the insurance premiums for the private patients continued to rise at 20–30% per year, to the point that there were a number of private patients that couldn't afford to buy insurance. So those people ended up going with no insurance. They would end up with a serious illness in the hospital. We would not turn them away. Everybody gets treated if they're ill and come to a hospital. And so we would treat them, but that cost was shifted to the private pay patient. And right now we've got about 35% of the people that go in the hospital that pay a full dollar for dollar service, and then they pay an additional premium to cover the uninsured and the inadequately insured, and to cover the uninsured and inadequately insured, and to cover the Medicare and Medicaid population. And we've got 300,000 millionaires over 65 on Medicare that don't need Medicare. And that money could be utilized to take care of the people that can't afford to pay for themselves. So basically the solution that Healthcare 2000 recommended was, number one, from the Medicare standpoint, that we accept the personal care plan that I told you about. So we say that anybody under 150% poverty level, whatever the government can pay for those services, we'll accept that. For anybody over that, they have to pay the same thing that anybody else pays. And those 300,000 millionaires can buy their own private insurance, or they can have the Medicare system, but they have to pay a premium to cover that cost. So that Medicare monies that are taken in and can take care of the indigent and poor people. We went into some cost-saving things that I won't have time to tell you, but there are a lot of ways that we can save money and cut costs in health care. So we had a long list of things, and one of them had to do with death with dignity and living wills. And one of the things that we recommended was that we educate people to help physicians not put people on respirators and keep them alive another 3 or 4 days when we know they're going to die. But we're scared not to do all this because of suit. So living wills now are handed out in hospitals and in legal offices, and a lot more patients now are becoming knowledgeable about this, and we're getting them on their records, and we're not having to put them on respirators when we shouldn't be doing that. But anyhow, without going into all that, there was a lot of cost saving. But the Medicaid and Medicare are now paying $1 for health care if we had this system for the dollar health care they receive. We've got the older population paying for what they can afford to pay within the means testing of what they can afford. And then we required everybody to have health insurance. Now, it was interesting, after I announced this at the annual meeting and our House of Delegates approved Healthcare 2000, a newspaper reporter stood up and said, "Dr. Brake, do you mean to tell me that you're going to require me to have health insurance? This is a free country. You should not have to require me to buy health insurance if I don't want to buy it." And what I told him was that if you want to go out and buy a motorcycle and ride down the road, it's a free country and you can do that. But if you flip that motorcycle and you get a fractured cervical spine, or you get a serious illness that puts you in the hospital and you run up a $100,000 bill, you have no right to make me pay for that. And I'm the one that pays for your hospitalization because my premium pays for it. When I pay my premium, it pays for the people that go in the hospital that don't have insurance. And you have no right to make me pay for your health care. You ought to have to pay for your own health care. So it's my opinion that everybody should have health care, and Healthcare 2000 said everybody should have what we call a basic benefit package. We drew up a basic benefit package now that says the things that we think every American should have as far as health care is concerned. And then you have to look at, well, how do you implement everybody having health care? And a lot of debate is going on right now. It'll be interesting to see what happens over the next few years as whether or not this is going to be required for employers to provide health care for their employees, or whether or not within that there are to be tax incentives. My personal belief is that I think that we as Americans should be responsible for ourselves. And the more we depend on government to do for us, the more problems we're going to have. And so from that standpoint, I feel like that people should know what health care costs. And if I am going to have health insurance and I get a salary, then the amount for that premium for that basic benefit package should be on my check, and it should be deducted from my salary. And if we're going to have a tax benefit, then the tax benefit should come to me. So I get the tax break for the amount that I pay. And that way I can look at that, and if it's going up too high, then I can start looking into why. One of the problems in this country has been that industry decided that one of the benefits we're going to give everybody is health insurance. And at that time it was cheap. And now it's so expensive that industry is having trouble paying for it. And now everybody expects it, and industry should give it to them. So Healthcare 2000 says that we ought to have everybody covered. Now, some interesting things would happen. If everybody, all the uninsured were covered, Medicare and Medicaid pay $1 for $1 service, we don't have this cost shifting anymore. Everybody goes in the hospital now, the hospital gets paid. So all of a sudden, we have an increase in money in the hospital. All of a sudden, the insurance companies have an increase in money because they've got all these people, that 37 million people are uninsured right now. They're all paying premiums. The doctors are getting money because all the people they're treating free now are paying through the insurance. So within that system, we should be able to see the insurance companies' rates come down so that people can afford them. Now that we don't have the cost shifting. And within the system is going to be some mechanism to monitor hospital costs and physician costs and insurance costs to make sure that they just don't take a windfall of money in, and that they are giving it back in the sense that people get lower insurance premiums. So that's what the Healthcare 2000 of 1992 is. And I wish I could be here 50 or 60 years from now and find out what kind of system we have, but hopefully it'll be a good system that our children will have good quality health care, and we won't destroy this into some socialized system.
Tell me about, from a more personal perspective, what are some of your fond impressions of your year as president of the SCMA?
Well, being installed as president of the South Carolina Medical Association at this big banquet with your friends and dignitaries around, and to have a standing ovation of your peers that respect you is just an overwhelming feeling. And I had friends to come to that banquet that I haven't seen in a long time. I had phone calls, I had letters, I had copies of newspaper articles sent to me from people I hadn't heard from 10 or 15 years. And those kind of contacts and that kind of friendship was tremendously rewarding to me and very humbling.
Are you enjoying more your return to private practice?
Well, one of the things that I think the Medical Association needs to do, and I know this is something that the time that you dedicate to the Medical Association is time that we dedicate, and for the organization to be able to function well, we need to keep the expenses down as much as we can. But the amount of time out of the office that a president takes is a tremendous cost to him. We had one president before me that basically lost his practice. After serving a year, he went back. His patient, he was a solo physician. His patients had all gone to other people, and he never got back into practicing in that community. He did administrative work after that. And he was one that recommended that some reimbursement come back to the president and the chairman of the board and the president-elect. And there now is a small fee that's paid to them for that, but it really, right now, after 2 years, my practice is, it hurt my practice, there's no way to say it didn't, and my practice is just getting back to the way that it was before. I have still stayed active in the Medical Association and served as an alternate delegate, and now I'm a delegate to the AMA, and probably will do that until medicine, the healthcare crisis is solved, or whatever outcome we have over the next 3 to 5 years. And once that's done, then I'm going to retire. I think back to the early 70s when Dr. Gillen told me to get involved. and serving on the peer review committee, we disciplined physicians, and I felt very strongly, and as a young idealistic doctor, that the only person that's capable of judging and disciplining a physician is another physician, and that if we're not willing to stand up and tell physicians when they're practicing poor quality medicine or overutilizing services, then we're just not doing our job as a total physician and representing our patients as we should. So I felt strongly from that standpoint. I felt strongly that I should be involved in trying to shape medicine so that we can continue to provide quality care for our patients. I was active in the Academy of Family Physicians during the early 70s and actually early 80s, and served as chairman of their board and president of that organization for the state in 1985. And moved more into the South Carolina Medical Association because the South Carolina Medical Association is more effective as a larger organization. They're able to get more things done through the legislature than the Academy of Family Physicians was, and the AMA is able to do more on a national level than the Academy of Family Physicians are, and that's why, although I'm dedicated to family physicians, I feel like I can have a greater impact through the South Carolina Medical Association and the AMA.
Are you optimistic about the future of medicine?
Yes, I am. I'm concerned that a lot of this has to be done through the legislature, because I have not been real impressed with our Congress over the past 5 to 10 years, as I don't think anybody has. They have been fairly ineffective in making decisions, but I'm encouraged in that to see bills passed that impact health care, that we actually initiate. And on a state level now, we have legislators that call us about bills, asking our position, giving them guidance, and have built a tremendous reputation and respect in the legislature on the South Carolina level. One of the fun bills that we passed that I'm having a great time with right now is that for the people that may watch this 10 or 15 years from now, there was an evolution in healthcare and trying to cut costs, and since the industry was buying all this healthcare, then the industry decided, you know, you guys have been calling the shots, now we're going to take over and we're going to call the shots. And so they started forming these utilization review companies that actually pre-certify. If somebody's going in the hospital now, you just don't put somebody in the hospital. You get a call from the insurance company, want to know why they're going in the hospital and what are you doing in the hospital you can't do out of the hospital. Well, the people that have these companies have sold the industry a bill of goods that they are saving them large amounts of money. And so they have no regulations on these companies. And some of them are operating out of California and New York and all the other areas that have nothing to do with South Carolina, that are operating out of one room with one telephone, and patients now are aware that if they're not pre-certified before they go in the hospital, then they're going to have to pay for their insurance ain't going to cover them. And so I've had patients that I couldn't get to go over the hospital until we could be sure that we got through this phone. Well, if you got 1 or 2 phones in one room and you got 500 calls coming in, obviously you got a lot of busy signals. And so, and also they set up as far as who calls you on the telephone, people would call that had no medical knowledge. And if you put somebody in the hospital with acute myocardial infarction, it's easy to say this patient's had a heart attack. That's all I need to say. You can look up in a book and say how many days you need to allow me and call me back in that number of days. But they would ask you questions like, well, doctor, what did the EKG show? And doctor, what are you doing for him in the hospital you can't do at home? And those were just standard forms that the people had no medical knowledge to know that you don't treat a myocardial infarction at home. So we got a bill passed in our state that said that these companies have to register with our insurance commission. And we set up some guidelines. And now we have to be able to reach them within a certain period of time. They have to answer the insurance commission. And now when I get calls, if they put me on hold for a long time and they finally get on the line, then I'll ask them what their South Carolina number is. And a lot of these companies, I say, where are you from? Well, I'm from California. Well, what is your South Carolina number? Well, what do you mean by South Carolina number? Well, you know, if you're taking money from a company and you're going to do review work, and you're using South Carolina, you call in South Carolina, then you're operating illegally in the state. And I don't have to give you any information about the patient. And if you deny this admission, then you know, we'll have to notify the company you're taking money from and you can't even operate in the state. And so it's been fun playing games with them to get them onto the fence for a change. And actually, I wrote a letter to the insurance commission about one company that I tried 3 times to get through and was on the phone for 20 minutes each time, and got calls from the company apologizing. They set up more phone people to cover the cost. So, you know, that was a bill that was passed. It's helped the physicians and has probably helped control some of these companies.
So perhaps it won't be as inextricably intertwined between the legislative and medical health, the health of medicine itself, for as long as ever. Would you do it all over again?
Yeah, I sure would.
Yeah.
It was fun. It was really fun, and now the relationship that I've developed with the board members and Bill Mann, our executive director, has been a relationship of not only healthcare providers that we work with, but friendships that I'll have forever. And it was just a great experience. I would recommend it to anybody.
Thank you, Dr. Brake.
Yes, it's my pleasure.